those that don't know me, I'm Jack Turner, so I oversee medicines negotiations for NHS England. And I've had a fairly meandering career path into this space, which has involved working in the Department of Health, working in industry for a little while, and then in the MHRA as well, before joining the NHS a few years ago. And I raise this point because I think we all collectively, over the last 10, 15 years, have had a tendency to work in our silos. And actually, a theme of what we're all talking about and what I want to kind of get across today is that to get the right treatments to patients, we need to start thinking much more about how we break down those silos and have a holistic access pathway. And I think taking that forward is going to require all of us working together and providing insights into that. So working as a payer, we are at the kind of end of the chute of that pathway, if you like. And a lot of what we do on the kind of policy side of pricing and access is try and understand what the changes are in the global environment, what's happening in the MHRA, what's happening in NICE, and how do we respond to those things? How do we respond to the evolving medicines pipeline? Our comms officer actually gave me some notes this morning which said, start off by saying, it's been a busy year for pricing environment, which I think, given the US-UK deal, is probably the least understated thing I could say. We are in a period of rapid change, and a lot of that has been driven recently by the conclusion of the UK-US pharmaceutical agreement, which has a number of commitments that have been made. A few things I just wanted to call out on that. So one is we now have spend targets for new medicines, so increasing the percentage of spend on GDP to 0.35 by 2028, 0.4 by 2030, and 0.6 by 2036, so doubling the amount of money we spend on new medicines. We also have a commitment on all medicine spend to go from 10% of the NHS budget to 12% by 2036. Alongside that, we have changes to the voluntary agreement for pricing, access and growth. Currently for new medicines, there is a cap on the total medicine spend, which means anything that we have over the allowable growth rate each year gets rebated back to the Department of Health and then comes back to the NHS. We are now moving into a system, as per the US agreement, where that cap is set at 15%. Anything above that 15%, the healthcare system has the risk for now, moving forward. So the good news is there that we have two things. We have a much more risk-sharing, risk-based approach between industry and government for medicine spend. We also, for the first time in a very long time, as payers, have a mandate to spend more money on innovative medicines, which sounds great, right? Because, you know, we've historically come from a system where we are encouraged as a monopoly purchaser to secure the best value, which frankly is code for the best price possible. And we are now recognizing much more the value of innovative new treatments. Now, the consequence of that change to the voluntary scheme, though, is we no longer have the protection we used to have if we have an overspend on medicines. So for the first time in a long time, we also, in a very real way, have to very carefully manage our budget and make sure that we are managing it within the final financial envelope that the government gives us. So we have to be careful of that, but what that means is that we will increasingly be looking to spend more on medicines in areas that have the greatest patient benefit, which typically is in areas of the highest unmet need or areas that have the opportunity to transform the system. So very topical and relevant for this audience. Some of you will be aware as well that we are currently working across all government departments to look at what does a US-UK agreement mean, and Number 10 and Her Majesty's government have commissioned a further rapid review into do we need to make further changes to our access policies and our uptake policies. That work is currently underway and will result in some pilot concepts by June this year. Those pilots will then inform, for the access environment, what we do in the NHS to pay for new medicines and lead to an update for the NHS commercial framework for new medicines. And we will be launching, I hope, a public consultation on that by December of this year. So keeping with the theme of what does this all mean as a payer and how do we respond? We heard from Lawrence earlier about some of the changes that are happening in the regulatory space, which for rare treatments is where some of the biggest change is happening. And I wanted to flag a couple of things. So one, in April this year, the MHRA and NICE announced their new aligned pathway, which aims to get medicines to patients 3 to 6 months faster. It's a really good opportunity for us to work across the system and make sure that we're aligning as much as possible the announcement of a license, the announcement of a HTA decision, and also getting reimbursement available for those treatments at the point of NICE recommendation. So it's an opportunity if we all come together and companies work through that process to really speed up access for new innovation. There is a challenge for that for rare because the data requirements that NICE require for a cost-effective assessment are far more onerous in terms of long-term data than they are for the regulator. So typically, companies that want to go through that will have to make sure that they are NICE ready and actually have the cost-effective model before going into it, and should put their information into horizon scanning at least 3 years before. So it is a great initiative to get more alignment, but it will only work for a certain type of model. That's why we're all very excited to see the work that the MHRA are doing around the rare disease pathway and proposing an investigational marketing authorization. It will start to create an opportunity for treatments in rare that have smaller clinical trial footprints that can be granted based on compelling but limited evidence, and then looked at in a kind of modular way. Now, this is all very, very exciting, but it will only work if the system joins up to meet that. And at the moment, we don't have the processes in NICE to actually make sure that they will be able to effectively take that license and put it through a HTA system under their HST process. And we do not have the funding models in the NHS to think about how to do that when it is so early on in the pathway. So the consultation exercise for this is going to be vital, and all of us are going to have to be putting our minds to how we can make this work in a new and different way. For those of us in the NHS as payers, it's encouraging us to think much more about what is the future of managed access? How do we use our Innovative Medicines Fund to fund the rare treatments that could come through? Do we move that funding up earlier in the pathway? Do we think about different exit criteria for managed access? How do we make this work in practice? And we will need insights and expertise from everybody in this room for that. Lots of changes in NICE as well, as a consequence of the US-UK agreement. So for the first time since the threshold of 20 to 30,000 has been in effect, there has been an increase to 25 to 35,000, which means that medicines will now be able to get through a NICE technology assessment and achieve a higher price for the same level of ISA. They're also introducing a new EQ5D, which I'm conscious that I don't know how many health economists in the room, but the basic level of my understanding of this is you currently have one with 3 criteria, you're now moving to one with 5 criteria, so it will mean that it's a more granular assessment of utility, taking into account things like care benefit, fatigue, cognition much more effectively when you're demonstrating the quality that goes through NICE. Now, these things are significant shifts. The NICE threshold change was something that has been a huge, huge change in government policy and will lead to higher spending on medicines, higher prices, and more treatments being recommended. For the rare environment, I think there is still more work to do, and the criteria and increase is not being applied to the highly specialized technology assessment, although that still remains much, much wider from 100K to 300K. Changes at the system level, you can tell that we all work in quite close collaboration because Kath has already spoken through a lot of this, so I won't labor the point too much. But the rare disease framework and the 4 pillars of getting a diagnosis faster, of increasing awareness for rare diseases, of better coordinated care, and improving access. I think having those 4 pillars since 2021, and then having each of the nations translate that into action plans that are updated on an annual basis, has really driven us forward in a way that is fundamental and has led to real system change. There is still more work to do. I think there's a lot of questions and opportunity around what the framework will look like in the future. And as Kath said, I would encourage you to engage with the Genetic Alliance to feed into this process to make sure that we are collecting insights. The work of the new framework is really going to be underpinned by the commitments in the 10-year health plan, and you'll have noted the commitments there for widening access and early screening and making sure that we do more on that. The generation study, as Kath was saying, is pivotal to achieving that, working across the NHS and Genomics England to screen 100,000 babies, newborn, to improve our ability to diagnose via genetic screening. And we have a commitment as the NHS as well to look at an operational framework for individualized genetic therapies, because again, these treatments, while extremely exciting, do not currently fit with the access and pricing pathway we have. If you have an N of 1 treatment, it is extremely hard to demonstrate cost effectiveness with the system we have. So we need to challenge ourselves now to think about how do we do things differently, and how do we bring together the commissioning expertise, the service delivery expertise, and the payment models to make these treatments work and go from a license right through to patient bedside. And that is a challenge of that group and the commitment that we as the NHS have made to ensure there is an operational framework that starts to work these problems through. And I just wanted to finish with a call for opportunities for engagement. So you've heard from Lawrence that there's going to be a consultation in, I can't see the MHRA folk in the room, but I think 10 days, Julian? 10 days? I'm getting a nod. Please engage with the Genetic Alliance on the rare disease framework and action plan for the future. There are also a couple of more technical but very important opportunities to engage with NICE at the moment. So one is their consultation on their manual, which is being put out because of the update to the cost effectiveness threshold. Now that is an opportunity for the rare disease community to also raise things that they feel need to change as part of the HTA system. Similarly with the EQ5D. And as I said, once we have gone from the US-UK agreement through to the sprints that we're currently doing at the moment, which are looking at how we need to reform our access and uptake environment, we will then have some pilots, and then that will come out of the machine with a consultation on the commercial processes we have to say yes to new medicines and make sure that we are getting clinically and cost-effective treatments to patients as quickly as possible. So please do look out for that. We need to work collectively to make sure we get the right system in place across all of our partners. And that is not the job of one organization over the other. That is a system-level commitment we need to come to. I think that is my last slide, so I will say thank you very much.